Good morning, everyone. Welcome to our session, Managing Cystic Fibrosis, One Transition at a Time. Happy Saturday and last day of the conference. We're really glad you all are here. I'm biased, but I think this is going to be a really excellent session with a really diverse range of speakers talking about really important topics that include different types of transitions, so developmental stages across the lifespan. So thank you all for being here, and thank you to our speakers in advance. I'm Emily Muther. I'm introducing on behalf of my co-moderator, Bryn Arnall. Here are our disclosures. And just to remind you all of our objectives, our hope today is to be able to describe clinical data that's been obtained from people with CF and their families related to priorities and areas of concern that should be addressed by members of CF care teams during critical transition periods. Identify suggestions for improving CF care based on the data and clinical initiatives that will be presented this morning, and discuss how findings presented impact people with CF and CF care team members across both pediatric and adult settings. Just to mention, we will have five presentations. Some of our presentations have a few speakers. Each presentation will be about 15 minutes. We will have time for questions at the end of each talk. Feel free to use the app. We'll be able to see questions and we can read them from the podium. Otherwise, we have a microphone in the middle of the room and one that we can bring down if folks are more comfortable asking the question from your seat. And then at the end, if we have time, we can also do a Q&A with our panel.
Okay, and I will introduce our first speaker. So Melissa Allow is a clinical social worker with the pediatric and adult CF teams at Boston Children's Hospital / Brigham and Women's Hospital. Melissa has over 20 years of social work experience in a number of roles and settings, with the last almost 5 being in CF. She works primarily with adolescents and young adults in both CF programs, with a special focus on healthcare transition from pediatric to adult-centered care.
Thank you both so much for inviting me. I want to apologize that I am losing my voice. I preserved it as much as I could this morning and wouldn't even speak to my roommate. These are my disclosures, which there are none. So this is the agenda I'm going to go through today. So I want to start with what is healthcare transition. So this is from gottransition.org, which I definitely recommend if you have questions about transition that you go to their website. I am not paid by them at all, but they're great. The process of moving from a child family-centered model of healthcare to an adult patient-centered model of healthcare, and that can be with or without transferring to a new clinician. This should be an organized process in both the pediatric and adult healthcare practices, and we're looking at facilitating transition preparation, the transfer of care, and then integration into adult-centered healthcare. So I work at Boston Children's Hospital, and I'm sponsored at Brigham and Women's Hospital. Our pediatric program is all at Boston Children's. Our adult program is in both places. So our outpatient clinic is at Boston Children's. We have a separate adult clinic. And then our inpatient specialist, ED, emergency department is at Brigham Women's Hospital. So we're in a very unique position, and I get to work with both programs. And so this is really the population that I focus on. So we wanted to do some quality improvement. So we wanted to really assess what's the level of satisfaction with the pediatric CF team's discussion about transition-related topics, understand how informed the young adults were feeling about their transfer to adult care, and then utilize this feedback to inform our transition process. gottransition.org, I swear I'm not being paid by them. I like this visual because I think when people think of transition, they often think of the pediatric side of things, and I think we need to make sure that we're also thinking about the adult side of things. Transition is a process. There's a transfer of care in the middle there, but we really need to look at that. And if you look, both pediatric and adult care should have their own transition and care policy and guides. So we did this in 2 phases. The first phase was a post-transfer survey. So we had a multidisciplinary team. It was a working group. We developed a survey that had 33 questions. It's a long one. We recognize that. And we got input from both the pediatric and adult CF teams. We identified who the young adults would be, who would be eligible. So patients had to be a young adult transferred to the adult CF care center in the previous 2 years, and it had at least 2 visits with their adult CF provider. We initially provided an anonymous HIPAA-compliant survey link that was sent via email by myself as the transition social worker to all of the eligible participants on 2 occasions, 2 weeks apart, and we got 1 response. And I said, okay, we need to switch gears. So then we took the survey, developed it into a paper survey, and we presented it to those eligible patients during their scheduled adult CF clinic visits. So at the end, we had 11 young adults who were able to complete the survey out of an eligible 37. The average age at transfer for this population was 20.8 years. This is an example of what it looked like when we handed out the paper survey. So we had a nice colorful flyer that gave them the QR code if they wanted to do it electronically. Nobody did. So we then clipped that to 3 pages, which probably felt a little overwhelming, but everyone completed all the questions. So there's lots of Likert scales, yes, no. We also provided some open-ended narrative at the end so we could figure out, like, these are the things that we thought as a team, like, we wanted to know, but were there other things that the patients actually wanted to tell us that we didn't even think of? So some of the results, pardon me, 100% felt that their parents or caregivers were involved just the right amount in their transition preparation. 82% had met with their pediatric CF team alone prior to transfer. Seems like a great number. I'm also focusing on the 18% who did not meet with their pediatric CF team alone at all before they transferred to adult care. Of those that had met individually, 33% felt that it was somewhat or very important to them to have time alone with their provider prior to transfer. 100% had met someone from the adult team. It's kind of a cheat because I work with both teams, and most of those were me. We did have some that were able to meet with one of the adult doctors. We have a nurse practitioner who often meets with our young adults while they're still in the pediatric program, like if they have sick visits. It's a nice way to also transition and get to know another member of the team. Our lovely dietitian is also able to work with our pediatric patients and often will meet young adults as well before they come over to the adult team. 45% said they would have found a video about transition helpful. I have no AV skills whatsoever, so I was like, oh, this is something we need to look at. And 36% thought it would have been helpful to talk to another person with CF about transition. So these were the key takeaways for myself, for the team. We would look at satisfaction, and I apologize if it's super small, but hopefully you can see here. So when we're looking at the key takeaways, what I'm finding is that I think we're doing a pretty good job. Most people were feeling very or somewhat satisfied, but the things that stick out to me are health insurance and medical costs, which we've been hearing, I know I've been hearing a lot about at this conference. And we really need to do a better job, I think, about the transition and transfer process and how we're explaining that to patients and to families. We asked them how independent they felt taking care of their own CF care before they transferred. I was really happy to see that 64% said they had some independence, which is great. 18% said they had close to complete independence, but there's still that 18% that felt they had very little independence before they transitioned their care to the adult team. We asked their perceptions about when this pediatric team started talking about transition with them. 27% said it was too late. They wanted it to be sooner. I don't care about the 73% when I'm thinking about QI. I'm thinking about what do we need to do better. And then thinking about understanding of adult CF care at the time of transfer. We weren't doing so great. So I'm looking at, like, I just explained that we're at 2 different hospitals. So when you're an adult program, You go to a different hospital for the emergency department and inpatient care, but you're still at Children's for outpatient. So only 27% of our patients felt somewhat informed about the processes for the emergency department and inpatient care after they had already transferred to our program or had already had 2 visits at least with the adult program. No one felt very informed. The other thing is, it's hard as a transition social worker not feel responsible, like, oh my goodness, I didn't do a good job. I handed them a flyer. But we need to do better at saying these things over and over again. It can't just be a one-time conversation. So we wanted to dig a little deeper. Pardon me for a second. So phase 2 was listening sessions. We really wanted to learn a little bit more from people directly in an open narrative format. So we had one team member who was able to conduct brief qualitative listening sessions with eligible young adults. And these young adults were 18 and over with CF, and they could be followed by our pediatric or adult CF centers. And so they could be pre or post-transfer to adult care. We had 8 young adults with CF that participated, and 5 of those were pre-transfer to adult care. The sessions were not recorded, and notes for the sessions were analyzed using content analysis to develop themes. Each person that participated in the listening session was able to get a $5 gift card for their participation. It's really important to get patient voice. It's also really important to compensate them for their time. This is outside of their care. And yes, we're curious, we want to improve their situation, but we have to compensate people for their time, if at all possible. These were the guiding questions. Mainly, can you tell me about your experience transitioning or getting ready to transition from the pediatric to adult CF program? And around when did you start getting information from your pediatric CF team about transition? So we found that young adults recalled transition conversations starting at a variety of ages, some as young as 14 and some as old as 19. The majority of them said it started at 18 or older. And then one person said it was only 6 months before they transferred care to their adult center, and they were 20 when they transferred to adult care. I'm going to give you some quotes. The current pediatric care team is focused on the present, not the future. If it's possible, it would be helpful to meet with adult doctors while still under the care of pediatric doctors. I didn't plant this quote, but it pretty much wraps up all the things that we were looking at. This person said more written materials, checklists, and planning for future health, like reproductive health, GI, bone health, diabetes, etc., would have prepared me better for knowing what to expect, who to see, what to look out for, and most importantly, what questions to ask prior, during, and after transition. And we had one lovely individual who said, adult care is awesome. I think some of the other takeaways is, when we talked to those who were pre-transfer, they were scared. Transition is scary, and they didn't want to have to talk about themselves from the very beginning all over with a whole new team. Because let's be honest, everyone has access to the medical record, but if I'm meeting a 21-year-old for the first time, I don't have time to read through 21 years of medical records. As a social worker, my role is obviously very different than a doctor. The other thing that we found is in these listening sessions, lots of words were used to describe our transition discussions. Vague, very minimal, bare minimum. And I think we thought we were doing a really good job. And I'm really glad that we had these listening sessions because we were able to find out for not for everyone, we weren't doing a great job. So we obviously want to use this information and inform our transition process. So what we found in these themes is that our young adults were expressing a desire for more structured transition preparation from their pediatric CF team. The topics related to living with a chronic illness as a young adult were identified as educational needs during transition. And they wanted more detailed information about the adult CF program prior to their transfer. So I'm just going to give you a little breakdown of what our multidisciplinary transition working group has been doing since 2024. I realize that we're almost at the end of 2025. So what I would say to you is if you're looking to adapt your transition process or developing it, be kind to yourselves. It takes time. There's so many layers here. This isn't just, oh, you know about CF. This is who your doctor is. Go on your way. So the things that we've updated so far, we've updated our transition policy. The last time it was reviewed was pre-pandemic. We developed a transition letter for patients and families to explain to them that this is what transition is. This is what we're hoping to do. We have quarterly meetings with both the pediatric and adult teams that meet to talk about patients who are eligible for transfer of care and those who are needing to transfer. And so we updated our meeting template to include additional information that we found was lacking. And we updated the track, which is the Transition Readiness Assessment Questionnaire. In EPIC, what we found is there was a random version in EPIC that no one knew where it came from and no one could find it cited anywhere. So I'm glad that we picked up on that because now everyone in the hospital at Boston Children's can use the appropriate version of the track. Things that we developed during this process, we developed an education framework that was divided by age and developmental and stages. We obviously did this post-transfer survey and listening sessions, and we also developed an EPIC flow sheet for tracking the transition education materials that we were going to be providing to patients. Things that are in process. We're now determining the feasibility of including the track caregiver, which is a readiness assessment for caregivers of adolescents and young adults, into EPIC. And we are trying to figure out how do we implement all of these things in our clinic workflows. An example of our transition policy, which you probably cannot read. Our meeting template is something that is created by the entire multidisciplinary pediatric team. It is presented at the meeting with the adult team and is provided to the doctor who will be seeing this patient once they transfer their care so they can refer back to it. We also include their PFTs. Things that are important too in our center we added were preferred pronouns, gender identity, guardianship, because just because you're 18 doesn't mean that you are just a legal adult responsible for your own decision making. We do have patients who are under legal guardianship through their probate court. This is an example of what our education framework looks like. So we broke it down by these age groups. I put them in quotes because it's really about developmental stages. I gave one example from each. This document at this point is, I think, about 10 pages long. What you'll notice is that what is the topic and who is assigned? And there's multiple disciplines. So everyone on our team is included in this document, from our pharmacist to our nurse coordinator, social work, the doctors, and we have the resources directly here so we can click on the link, go directly to it, pull it up if we need to. We're also trying to integrate this into our multidisciplinary review team meetings that we have every week and saying, okay, this patient is coming in, what stage are we at in the transition process? What needs to be presented? I did not do this work alone. I would like to give a special shout out to Catherine Melton, who was our nurse scientist who was able to do the listening sessions with us before she left. This is my wonderful pediatric team. Several of them are here in the audience right now. I wanted to thank our colleagues at Brigham and Women's Hospital, Boston Children's, Adult CF Center, and a special thanks to all the young adults with CF who gave us their insights and their perspectives. References. Thank you. Yeah, stay here. So I know I said thank you, but I have one more thing. I'm a social worker and I want to give resources. So if you are interested in getting resources about transition for care teams, for adolescents and young adults and families, you can email me and I will be happy to share my slides with you because the next 4 slides, which I'm not going to show you, have all those resources for you.
Wonderful. Thank you so much, Melissa. Your team and you are doing amazing work. It's wonderful to hear some of the examples and data, both qualitative and quantitative, that you've collected. A reminder to please put questions in the chat. Brennan and I will read those after each speaker. Or if you want to ask live at the mic, please feel free to do so. I'm going to ask one question, and then folks feel free to ask a question. I'm wondering, in all your expertise and experience, if CF care teams were interested in beginning the process of improving transition for their patients, what is the first step you would recommend that they do?
Well, what I think I've learned in the almost past 2 years while we really sat down is there needs to be buy-in from the team. And so you've got to find the champions within your team. I feel like it started mostly with myself, my nurse coordinator, and our QI specialist. So we sat down and started the process. And then as we were developing, we were like, all right, who on our teams can we pull in from these particular disciplines? And you can send out a mass email. Most people don't respond to mass emails quickly. So we would go to them individually and say, hey, we really need your input. What are the things that you are discussing with patients and families? What are the materials that you want us to have? And I feel like that was very much appreciated by the team.
Thank you. Please.
Hi, thank you. Great job. Just curious if you guys use CF Rise. I know Dr. Sawicki was involved in developing it, but as a mom of 2 now adults with cystic fibrosis, I found it to be a super helpful program. In fact, I laugh about it because my son and I, he would do a questionnaire, I would do a questionnaire, we'd compare, and then he would sometimes score better than me in some areas. And of course, he loved that, but it was a great opportunity to learn just some of the details about, what CF's about.
Yeah, so interestingly enough, Dr. Sawicki is the medical director at our pediatric program. He was involved in CF Rise, and we don't use it as it was developed. We do use materials from it, however. So a lot of the developmental stages we use that, and looking at the tasks that teams are doing, it's really drawn from CF Rise. As a social worker, there's a lot of things I'm doing in clinic. The last thing I want to do is provide a quiz to an adolescent or young adult. It's like a pop quiz. What do you know about your chronic illness? And then you're not necessarily telling them the wrong, but you are. So for me, I want to take that information and just provide it to them instead of quizzing them. Because I remember being an adolescent and freaking out whenever I had a pop quiz in class. I can't imagine coming to clinic, having all these things on my plate. I'm meeting with 6 different people, and now you're giving me a quiz? And I don't want people to feel like I should know this and I don't, because if they don't know it, it's because the team has not done a great job of educating them so that they remember. So I love CF Rise and I use it all the time as a template, but I don't want to quiz people.
Thank you, Melissa. If we have time at the end after all of our presentations, we'll do a more thorough Q&A.
Thank you.
Our next speaker is Kate Yablonsky, and she is one of the social workers for the adult CF program at Stanford and has been with the team since 2018. Prior to working in CF, she was a pediatric oncology social worker. She'll be joined by Meredith Wiltsey, who is a nurse practitioner who has been at the Stanford Adult CF Center for over 10 years.
Thank you guys so much for inviting us. And I'm Kate, this is Meredith, and we're really excited to share an advanced care planning initiative that we implemented in our clinic. It's called the Serious Illness Conversation Guide. We don't have any disclosures. We're not fancy enough for people to want to give us money. So I just want to give you some background as to why advanced care planning is an area of QI our team decided to prioritize. And I'm likely preaching to the choir here, but I think it's always good to remind ourselves of the why of what we do. So there's tons of research that supports the value of advanced care planning. This is just like a quick summary. So it improves patient satisfaction. It reduces unnecessary interventions at the end of life. It makes it more likely that people will utilize hospice, which in my opinion gives people a better chance of having a less traumatic death and a death that is more aligned with their goals. It improves communication between the teams and it actually saves money. So we all work in these big healthcare bureaucracies where the bottom line is always hanging over our heads. And a lot of times the work that we want to do to make things better for patients does not align with the bottom line. And this is actually something that does. So if it's something that you're interested in or passionate about, you can actually get administrative support to do this kind of work because it does save money. And then, beyond the kind of like macro reasons that we do it, I think our team has our own personal reasons for this being important to us. For example, our medical director, Paul Mohabir, spends a lot of his inpatient time in the ICU, which I'm sure is true of many of the pulmonologists on your team. So he spends a lot of his inpatient time at the bedside of people that are dying and their families. And so he feels really, really strongly about having documented advanced care plans. And he has really made that a part of our team culture. And then, for me personally, luckily having come into CF in 2018, we haven't had as much end of life work to be done, which is wonderful. And a lot of the end of life care work that I did was in my previous role in pediatric oncology. So I feel really strongly about this kind of thing. And when I talk to my patients about advanced care planning, I tell them, this isn't really, I'm not talking to you about this because you have CF. This is a human being thing. And because we see our patients so frequently and we know them so well, we have a unique opportunity to give them a chance to have this kind of care planning in their lives. And we sort of feel like we would be doing them a disservice if we didn't bring it up. And when I explain to them why I think it's important, I describe it as like, think of this as a gift to your loved ones. Because if you're ever in a position that your advanced care plan needs to be used, something bad has happened, which means your family is stressed, right? They're in crisis, they're emotional, and anything that you can give them guidance-wise in a situation like that is truly an act of love. And I find that people are much more willing to do something for someone they love than they are for themselves. So I find that actually resonates for people when I frame it that way. So, we're like a couple years deep into trying to do QI related to advanced care planning. And I'm just going to flick forward to this other slide just for a minute. This is a poster that we submitted a couple years ago. The content on there is not important. I just want to give you an idea of, like, you see all that stuff on there, all of that work and effort. And we increased our patients with advanced directives from 9% to 10%. So it was a 1% increase. So it was a lot of effort for not a lot of, we didn't have a lot to show for it, right? But it's interesting because when we talk to our patients, people with CF generally agree that advanced care planning is important. They are very comfortable talking about it, much more so than some of the other, like I have another clinic of a different lung disease population, and these people are elderly, have lived long lives, and these young 30, 40-year-olds with CF are much more comfortable talking about their mortality than those older people. So it's actually kind of an ideal population to do it because a lot of these people have been thinking about their mortality since they were teenagers. So it's not that they don't think it's important. I actually think most of them really do, but it's just like a follow-through thing, which is not specific to people with CF. It's everybody. If you get an advanced directive, you have to notarize it or get it witnessed, and then you have to provide a copy to the clinic. And, people are busy, they have jobs, kids, lives, and they just don't follow through. So, we were, after our last effort, I wouldn't say failed, but did not necessarily have the results we hoped for. We tried to think about it in a different way. Like what could we do differently? Like, let's think outside the box. How can we approach this differently? And in thinking of QI, you have to have a variable that's in your control, right? Like, we can't control people turning in their advanced directive. So my previous social work partner, Meg Dvorak, who many of you know, we had the opportunity to do a training in a serious illness conversation guide through our social work department. And we really liked it. And then when we were trying to think of how we could approach this differently, we proposed to our team, why don't we try using the serious illness conversation guide as our advanced care planning strategy? And this is where the serious illness care program comes in. So I'm not going to spend a ton of time talking about the kind of high-level serious illness care program, but it's an initiative by Ariadne Labs that's been implemented in various degrees at hospital systems around the country. what we're really focusing on is the Serious Illness Conversation Guide, which is a free resource provided through Ariadne Labs that anyone can use. And if you are interested, just, in the sake of time, if you're interested in hearing more about the Serious Illness Care Program itself, I'm happy to talk to you offline and give you more information about it. But this is really the crux of what we're presenting today, the Serious Illness Conversation Guide. So I actually have this available to you as a virtual handout. So if you go into your app, you click on this session, and then you click on the sort of sub-session of me and Meredith's talk, I think down at the bottom right, you can click on the virtual handout, and it is this, what you see here on the slide, the Serious Illness Conversation Guide. So this is a scripted, structured conversation, and our thought was this covers what goes in an advance directive that we do as a conversation with our patients, and then we document it in their chart. So I'm just going to go through the what is in the conversation. So you set it up, get permission for what you're going to be talking about, and then you assess what their preferences are in terms of the amount of information that they get. So for most people with CF, not to overgeneralize, they tend to be high information people. They want a lot of the information, but in certain cultures, you don't share bad news, so it is important to assess how much people would want to know as their health changes. And then you share the prognosis, and admittedly, this guide was designed for, sicker people sort of approaching the end of life or with progressing, worsening illness, which, for most of our patients that we're doing this with, they're pretty healthy, and you'll see it's still applicable. But I think if you're doing this with someone who's much, much sicker, when you share the prognosis, that is a really heavy part of the conversation. But as Meredith will share later, this is usually a pretty straightforward part of the conversation for most of our patients. The prognosis is uncertain. Of course, anything could happen, but we expect them to do well for a long time. And then the explore section is really the meat of the conversation, where we really get a lot of good information from our patients. So we ask, if your health gets worse, what are your most important goals? What are your biggest worries? What gives you strength as you think about the future? What activities bring joy and meaning to your life that you can't imagine living without? If your health gets worse, how much would you be willing to go through for the possibility of more time? So this is really, if you can capture this information, you have an advance directive, basically. And then, we close the conversation, reflect back what we heard, and then we document it in the chart. And I am going to hand it over to Meredith, who's going to talk about how we implemented this in our clinic.
Hi, I was very fortunate to be conscripted into this. It was definitely social work inspired and driven, and Kate has done 99.9% of the work. So just here to present what it looks like from the NP side. So implementing, obviously, some of us had already been through the training for the Serious Illness Conversation Guide, and some of us still had to go through it. I would highly recommend it for anybody, even if you are not going to implement a program with it. It gives you, there's role playing, there's an app that you can work with, and it just gives you a tool bag of ways to have conversations with patients about challenging topics in a way that's empowering for them and insightful for you. And then we started our classic PDSA cycles to determine how to start this. And the way that we did that initially was we consulted with our parent-family advisory board and kind of brainstormed with them to get their ideas of what might work. And in fact, we incorporated a lot of those ideas, and in fact, did our pilot program with some of our PFAC members. So we kind of got their feedback from our initial efforts. So that was super helpful. We definitely, through working with the PFAC in those early days, learned that having a standalone video visit to have this conversation worked far better than trying to tack it on to a clinic visit where all kinds of other topics were being discussed, and it's such a different mood and a different set of goals. And so anyway, standalone video visit worked way better. And then we also developed our post-visit feedback system that we're still using now, that goes to every patient that goes we have the conversation with, and they are able to submit their feedback, which has further allowed us to sort of fine-tune the process. So the structure, Kate went over some of the questions, but basically we join together. We're typically, Kate and I or Deb, our other social worker, we join the visit. So there's 3 of us, the patient, sometimes family members join, and social work and myself. And we're typically in different places, so we're logged into the video visit from different computers. I do the first 3 sections. In other words, I sort of assess their understanding of what we're about to discuss, get their permission, they're interested in going forward. They're usually very intrigued, otherwise they probably wouldn't have shown up or requested the visit. And then ask for their understanding of where they think they are with regard to CF. And then after that I share my sense of their prognosis, because these people I've known mostly, I've known them for years and years and years. And so I think that piece of it really sets up the clinician participation piece of it. And then while I'm talking with a patient, Kate is there, but she's also, and we've told the patient about this ahead of time, she is documenting in real time, and we have an Epic template that allows for that, which means that we're able to capture their thoughts, we can free text what they say to us, and we end up at the end with a really rich document. Anyway, and after the first 3 sections, I turn it over to Kate, and she goes through the explore section, talking with patient about their goals, their fears, their sources of strengths, what's super important to them in terms of critical abilities in their life to make their life meaningful should they get sicker, what the trade-offs they're willing to go through, and then also introduces the concept of have you had conversations with your family members about any of this or all of this, how much do they know? And then assessing, is that something that you would want help with? Like, do you want to have us be present when you do that, or resources from us, or at least think about that topic? And then while Kate's talking, I'm documenting, and so we capture all of that as well. And then we come back together. We're both still on the screen, but we come back together and close the visit, and we are able, which is a great thing, to be able to do all of this and finish it up within the 30-minute time slot, which is excellent given the world we live in runs by time slots. So anyway, that's good. And I don't know that you can see this. This is the Epic template of the conversation guide. And if you can see that in the in the purple are the questions. What are your biggest worries at the top? And then what gives you strength and goes down. The graphic here is helpful because you can see that the guide gives us prompts or check boxes that we can say to patients to get them thinking about the types of answers that these questions are leading to. And then we can check the box if that particular comment resonates with them. But every question also has a free text box. And this is the part that I love the best because you can literally type in what they are saying in their own words. So for example, what are your biggest worries? The checkboxes are your ability to care for others, like your children or your spouse, your finances, your loss of control, being a burden, other kinds of physical suffering, or the free text. So this allows us to document and come away with essentially an advanced care planning document from this conversation, which can be changed at any time, but it's an incredibly rich document. And then finally, I'll say from my part is that going through this has really been a very personally enriching and professionally gratifying experience, because even patients that I've literally known for over 10 years and been in the hospital with them and clinic for years and followed their development and their sicknesses and all that, going through these questions with them, it has really deepened my understanding of who they are, what's important to them, how they got to where they are now on like a personal level, and really has enriched my care. I'll turn it back to Kate.
I definitely agree. A lot of times when I think about QI work, stuff feels like a slog, but this is actually professionally rewarding work that we really love doing. So it's definitely been worth the effort of trying to implement it. But because it's QI, I'll share just generally our results. This is a humble effort. We're not trying to get 100% of our patients because people are opting into it. You can see here, we've only done this conversation with 14% of our patients, and then we offer it, But, our goal is more so make this our standard of care. We offer this to our patients once a year, and then they opt in if they would like to do it. And just real quickly, the feedback, the big takeaway is, it's all positive. So our patients feel, a better understanding of the future health, control over medical decisions, closeness with us, hopefulness. And then this one, I think, I was just talking to another social worker yesterday who was saying she has members of her team that feel like, why would you do this with healthy people? And maybe they're worried that people will react negatively, but everyone that has done this conversation feels at least somewhat, if not more, that it was worthwhile. So obviously people are opting in, so it's a biased sample, but people are not experiencing this negatively, they're experiencing it positively. And I just included a couple quotes from our patients, just that it gave them answers to questions about their mortality, helped their medical team know what they want. And then, our biggest, what I hope your takeaway is that this is highly implementable. I love coming to the conference and getting inspired, and there's so much amazing science happening, but Meredith and I are trench workers. We don't have the ability to do a double-blind controlled trial, but this we can do, and this you can do. You can do this tomorrow. It's Saturday, so I guess Monday. You could do this Monday without any funding, without any extra time, and it's just incredibly rewarding work that is valued by the patients. So if you want to talk to us more about this or share resources, our emails are here. I also included Winnie Tudeberg, who generously offered her contact information. She's the director of our serious illness care program and also a palliative care physician. So if you have any people on your team or administrators that you think would want to implement the larger program at your hospital, she's happy to share her experiences. So those are our references, and that's it. Thank you.
Okay. We have 2 questions in the chat, and then that's probably going to be all that we have time for right now. So someone had said they're having difficulty accessing the serious illness communication guide in the app, and they were wondering if they just had another way to access it.
So I only found out 5 minutes ago that it was in the app, so I don't really know, but I can email it to you. So if I don't know if I closed the slide, sorry, but you can. I think my contact info is in the app, and I can email you a PDF. So please don't hesitate. I'm happy to send it to you.
You do have to go to the specific session for Kate in order to access it, not the overarching one. It is. I checked while we were sitting here. Just when that question popped up, but it is in there. So, and then someone asked, I love this template, seems very therapeutic and rich. I'm curious if after having the conversation with the team, are they offered the advance directive later on just to have a legal document, or have you found patients bring up thoughts in later clinic visits?
So great question. And actually that's part of closing the conversation. It's what are your next steps? And it's the options in the Epic Builder, do a pulse, do an advance directive, continue the conversation. It could be anything, but we have had some people I think maybe one person at least did an advance directive when she was done with the visit. And yes, then they ask more. So it can also be a bridge to people doing an actual advance directive, which is great. I hope I answered your question.
And then our next presenters are Lisa Green and Jen Weber. So Jen Weber and her husband are parents to 2 adult daughters with cystic fibrosis. They started facilitating parent workshops in 2007 in Charlotte, North Carolina. In 2016, as recipients of one of the inaugural CF Impact grants with collaboration from UNC Chapel Hill, they incorporated CF parent education groups. They have a website where workshop information has been archived since 2016. Jen's goal is to educate and empower parents. About a year and a half ago, after moving to New Hampshire, Jen started hosting workshops by Lisa Green, focusing on parents of newly diagnosed during her transition. In 2026, she and Lisa, along with 2 CF moms involved with the nonprofit, will present topics that represent different ages and needs. She is excited to be here today with Lisa and with this amazing CF community.
So we have no disclosures to release, but thank you very much for inviting us to be here. It's exciting. So our focus today is Bright Beginnings, integrating caregiver emotional support into CF care, which is Lisa's program. Let's see. So as was just said, my husband and I have 2 adult daughters with CF. When our oldest was born in 1999, the median life expectancy was 35. And I remember the doctor who gave us the diagnosis, as tears started streaming down my face, she said I needed to be hopeful. There was so much hope to be had. And we found hope in learning about CF from educationally focused workshops that were offered by our CF Care Center in Boston. And when we moved south 5 years later, there were no such workshops. And so that's why, as a school psychologist by profession, I had facilitated parent groups. And my husband and I decided we should try to do this for CF parents. And so through grants, we did start doing this in Charlotte to keep our momentum of hope going. And in 2016, like was just said, we started the CF Parent Education Group. And we started doing holding groups in North Carolina, initially just in the Triangle area, and then expanding through impact grants and community grants from the CF Foundation. And then through COVID, we went online, which we're still doing today. In fact, parents prefer, it's easier, and so we're just continuing online. Lisa Green's Bright Beginnings program, a robust print material program for parents of newly diagnosed children of CF, fits really nicely with our mission, and her program, as of 2014, is now part of CF Education Group. I'm going to turn it over to her.
Thank you. Thanks, Jen. Appreciate that. And it's really an honor to work with you. And I guess I didn't submit my bio, so I apologize for that. Anyway, so my name is Lisa Green, and I'm a mom of 2 young adults with cystic fibrosis, and I've been educating in the CF community, since my son was 2.5, and my daughter was, almost a newborn. So, just here for families, and my passion is as a family life educator. So in 2010, I started working with Audrey Toluchek, who many of you know. She worked with Dr. Farrell, who won his recent award, on a newborn screening project for the CF Foundation, and that started a professional relationship and a shared passion that continues today. Audrey and I collaborated on projects and wrote papers together over the years, and always dreamed of getting funding for an educational program for newly diagnosed parents, caregivers, and families. And we wanted to put our recommendations to practical action. So in 2018, we received a QI grant from the CF Foundation for the pilot program of what would become Bright Beginnings. For the pilot program, Audrey brought her expertise as a nurse, a licensed PhD psychologist, a researcher, and a professor at UW-Madison School of Nursing. Jen Drake, who's Audrey's colleague, is also a nurse and professor at UW-Madison. And as a mom of 2 young adults with CF, I brought the lived experience as well as my master's level education in family studies. One can never prepare for the words, "I am sorry, but your child has cystic fibrosis." That day, that moment is forever etched into my memory, heart, and soul, just as it will be for 1,000+ newly diagnosed families each year. Overwhelmed is the word mostly used to describe the newly diagnosed experience. The learning curve is huge, just at a time of intense emotional vulnerability and upheaval. Research shows high rates of anxiety and depression, isolation, and the need for support, practical information, access to medical care, and hope. Our pilot program was designed to address many of these issues and showed promise in addressing the challenges and needs. In 2022, we published a paper, which was also presented at NACFC, which was designed to increase our understanding of parents' experiences managing the needs of their children with CF and to identify potential gaps in services. 2 unifying themes emerged from parents' survey responses. First, parents' expertise expand continually as they learn and adapt to changes in their children's maturity or health. And number 2, parental expertise is sometimes visible or invisible to clinicians. We used a tree to depict the evolution of parents' expertise and resilience over time. This figure shows the growth of expertise of parents of infants and toddlers, which encompasses also the newly diagnosed experience. We have a different illustration tree for teenagers and young adults as they prepare for transition and transfer. So our research showed that parents' expertise evolved with their children's development. So you can see with the tree, and I know it's a little hard to read, but you can see it in our documents that are in the
the portal. But visible to care teams was at-home care, such as things like respiratory treatments, medications, the things that you all are aware of, that you prescribe, that you work with together in the clinic. But less visible were the intangible management activities, such as the social processes going on at home, the emotions that the children and the parents are experiencing, and the concerns that are always present for parents, but not always disclosed or seen or recognized by clinicians. Seeking support from other parents, learning, striving for normalcy, monitoring threats, constantly worrying about that cough that you hear across the playground, managing at-home care and the burdens that puts on families, how to do that, navigating healthcare systems. These are just some of the examples of the invisible things that go on in the families that you may not necessarily see or know about. But so that's where Bright Beginnings comes in. Our aim is to shorten the learning curve for families in the areas that CF teams are less effective. And it's important for you to know that our goal is to augment, not replace, the education that CF teams provide for families. So that's the background of Bright Beginnings, but what is Bright Beginnings? The program is composed of two main parts, asynchronous and synchronous education. We incorporated the learnings and feedback from the pilot program into what Bright Beginnings is today. We use a learning management system, or an LMS, which is Moodle, it's called Moodle, as the platform for 20 asynchronous or self-driven modules. For the synchronous part, we use Zoom to host live sessions to create connection and support, to normalize the newly diagnosed experience. And that's really a big part of what we do, to normalize that experience for parents and other family members, and also to provide hope and a positive outlook. And we also touch upon the core teachings of the different modules. So each live session, we go through, a different module that, the asynchronous module that we have in Bright Beginnings. So people can either log in and go ahead and read about it ahead of time or do some self-learning afterwards. But we kind of run through PowerPoint slides of what the module discusses, and then we talk about it and open up the floor to sharing. So the program is all evidence-based content with references at the end of each module, and the program focuses on the more emotional and practical aspects of a new CF diagnosis, not the medical aspects. The CF Foundation and CF clinics provide that kind of education for families. In fact, we specifically prohibit medical care conversations from our live sessions, and we refer participants to their care teams for those topics. We draw from many different theoretical bases, including, but not limited to, family resiliency and family systems, emotional intelligence, stress, coping and wellness, family-centered care, and partnership relationships. Our topics include, but are not limited to, communication about CF, relationship building, both outside of the family, with partnering with CF care teams, building relationships within the family, coping with emotions, and then managing day-to-day CF issues, managing medications, organizing medications. We talk about insurance, just many of the practical things that we face day-to-day. And we have lots of parenting information, which is really my passion, including tips for CF care, how to get young children to cooperate with their CF care, just really practical tips that we as parents face every day, and we've gone through it. And we also give a healthy dose of child development expectations from infants, and we go all the way up through preschoolers. We consider it to be like the first year to be newly diagnosed, but really it's 2 or 3, and we have folded in parenting tips for up to the kind of into the toddlers and preschoolers. So we look towards learning theory to design a program that would that would help parents best learn and retain the skills in each module. We encourage skill building through readings and writing or journaling prompts. We also have several video clips throughout the program from adults with CF and people from the CF Foundation. Lots of great resources built in throughout the program for families. We include quizzes and interactive materials to give variety and retain interest. And parents can access any module anytime free of charge. Again, this is designed to augment, not replace, education and support offered by care teams. And also, this program can be used by CF care teams to create a newly diagnosed support group in clinics. And so if you would like to do that, it's a great opportunity to have a separate newly diagnosed support group, and kind of like what we do with our live programming, run through the modules together and have discussions. One of our many comments from parents, Bright Beginnings took away my fear of loneliness and the unknown. It truly opened the door to CF without being terrified of what I'd encounter. Jen?
So how do you use this program? This is really the crux of what we want you to learn today. You can tell your CF care team and families the QR code. You can join our mailing list. Provide the website to newly diagnosed parents. We have a bunch of their postcards up here in packets of 10 you can take back to your clinic to hand out. Like Lisa said, you can use this for support groups for newly diagnosed. If you join our mailing list, you'll receive updates for workshops that are coming up. And in fact, in the portal, we have one coming up on November 16th. You can see a flyer for that's coming up. So and you're happy to email us too. Our email addresses are on the final slide. So we really want this program to be used. The materials that Lisa developed with her team are phenomenal, and parents can really benefit from them. So here are just some of the examples, visuals of our different resources, they are included in this session's handout. And again, we'll happy to email them to you. So the first one that you see, I know you can't read it, but it's the login directions to the Moodle platform. And it's a little clunky. We apologize for that, but we really don't want to just put it out there into internet world, which we could do, right? But then anyone can get on there at any time, and we're limited, to how many people can be running in the program at one time. And so we don't want just everyone in the world logging in, and we want to make sure that we have a safe place. The second one is, like Jen mentioned, an example of a flyer for Sunday, November 16th for our online live session. The third example is a document which I'm really proud of. We've been working on, and these are mostly, not all of them, are one-page summaries. We did our best to get them into one page, but some of them are front and back. But they're one-page summaries for each module, and so these are a great way that you can. They're approved by the CF Education Committee, and they're a great way that you can use them as talking points with your families. And if you're familiar with the different modules, we have 1 through 14. Maybe an issue comes up, and then you can, oh, okay, yeah, I remember, module 5 was about, focusing on building your relationship with your partner, right, or your spouse. And so, yeah, they mentioned they're kind of struggling. Well, here's some tips, some communication tips, and then you can refer them into Moodle if they want to dig more deeply and look at videos and learn some communication skills. The third document, and then the last visual is our postcards, again, which you can hand out to parents. And please take them. We don't want to bring them home. And they're down here. They're bundled in groups of 10. So we'd really love for you to take all of them. And so in closing, I developed this program obviously with help of my team, because it's what I needed long ago when my children were diagnosed. I had to learn things the hard way back then, and I want to help new families avoid some of the pain and the mistakes that I made through the years. My kids are no longer kids now. My son Jacob is finishing medical school in May. He's getting married, and we're hoping his residency will be here in Seattle, where we live. So that's very exciting. My daughter, who's
23, is thriving down in San Diego doing cancer research at Bristol Myers Squibb. And she graduated from the University of Washington in biology. Their health is excellent thanks to the new drugs available to them, and life is good with much hope and much promise for not only our family, but for most of us. And yet, I still remember, like every parent of a child with CF, we will never forget. We will never forget the moment of diagnosis, the place, the time, the smells, the sounds, the surreal sense of time. Is this a dream? We will never forget the shock, the disbelief, the fear, the anger, the tears, and the shattered dreams. And we will never forget the prayers, the hugs, the helping hands, the kindness, the love, and the hope. So thank you for all that you do. You make a huge difference in our lives, and you are also a source of our hope. So thank you so much.
Lisa and Jen, thank you both so much. Thank you for sharing this really important resource and guide and support, Lisa, that you've developed. And I think as we know, transitioning to parenthood is stressful, and certainly learning and adjusting to the transition of parenting a child with CF is extra stressful and difficult, as you mentioned. So I'm so glad this is available to help support parents of newly diagnosed children with CF. I'm wondering if you could mention if it's available, any of the resources are available for families in languages other than English?
Yeah, that's a great question. Thanks for asking. So in fact, Jen and I were just talking. We met someone. The challenge is always like in translation, getting things translated. I mean, it's expensive. We want to make sure it's done properly. Sure. So we're with our joining together now, kind of Bright Beginnings under cfparenteducation.com, which is really, it's a nonprofit. So that opens up more opportunities for us for funding and for grant writing, which we're going to work on that. And so, and we just actually met somebody locally here at the conference that might be a good first step for Spanish translation. So in short, the answer is yes, we hope to do that. And so it's,
Wonderful. I think one other question I wanted to just ask is, as we all know, there is an increased risk of depression and anxiety, not only in people with CF, but caregivers. And I'm wondering if you've thought about looking at the impact of your program on potentially reducing or buffering that risk for caregivers who have participated.
Yeah, thank you. We do have some of that information with the pilot program that we did. That was part of our pilot study. And so we saw some measurable, I don't want to say significant, because our pilot was so small, our sample was so small, but we did see some reduction in that from families. Anecdotally, we hear that a lot, but we have not studied it with the Bright Beginnings program as it is now, and kind of the more, it's not a pilot. I mean, it's a less robust research program. It's not a QI program. It's more of a community grant program. So, but it is something that we should look at. It's always a challenge, as you know, getting people to complete like surveys and give us information. And as you guys talked about being in the CF clinic, you tried to give people a survey online and nobody filled it out, and then they were in the clinic and then they fill it out. And so that's the challenge we have too. But we're not right in front of them, and so we do.
Well, we do have polls in our workshop. So we're doing pre and post polls. So we haven't looked at the data yet, and we're just starting to collaborate. But the anecdotal responses are that people feel that it's supportive.
Yeah.
So,
Wonderful.
yeah.
Thank you both so much. Okay, it is a great privilege to be able to introduce our next speaker, who I'm excited is a part of our session. Dr. Tracy Kazmersky is an associate professor of pediatrics at the University of Pittsburgh and a pediatric pulmonologist. She is a health sciences researcher who leads and is involved in many important studies, including one that she's going to be talking about today, the HOPE CF study. She also is a member of the PRIDE CF study, looking at and focusing on supporting LGBTQIA people with CF, and a member of or leader of the READY CF study, which addresses experience of males with CF and assisted reproductive technology. Thank you, Tracy.
Thank you so much for the invitation to present today. And on this theme of hope, I am going to be talking about the HOPE CF study. And this is part of the abstract number 717. We have a poster that's available that you can take a look at, but the abstract itself gives less data than I'm going to share with you today. And I'm presenting on behalf of a large team, and you can see them listed here, and they are really what makes this work go and helps us be thoughtful as we look at these results. So I'm going to talk about the impact of parenthood on the pulmonary health of people with cystic fibrosis, findings from the HOPE CF retrospective cohort study. These are my disclosures, and I just want to asterisk here that the NIH and the CF Foundation funded HOPE CF, and we're very grateful. So the goal of this study overall is to understand what happens to your health when you're a person with CF and you become a parent in this era of CFTR modulators and enhanced treatments. And this slide may seem familiar, but I think it's helpful to ground why we're doing this, because I think that when you're a person, any person, and you become a parent, there's things that matter. And there's things about you, like your age, your sex, your socioeconomic status, the path to parenthood you choose, and the number, age, and spacing of your children. There's been lots of theoretical modeling, though, that thinks about other aspects of life and health that come into play. And one of those is, what do your support networks give to you, and how do they support you and offer that to you? What is the impact and the interplay of your mental health on your physical health? And how does becoming a parent align with society's expectations that you do so? Secondly, we know that parenthood evolutionarily carries aging impacts. And then finally, there's lots of biomedical changes that happen to parents. There's significant hormonal fluctuations that happen with pregnancy, with childbirth, and lactation. Children can be stressful, and they can be a source of viral infection, especially those of us who had kids in daycare can attest to this. But they can also be a source of joy and this motivation for healthy behaviors and for purpose. So all of these things play together, and they influence your health as a parent. And what the HOPE CF study is trying to understand is what happens when you overlay a chronic disease like cystic fibrosis on this picture. So to do that, in AIM-1, we conducted a retrospective cohort study where we enrolled people with CF ages 18 years or older, and we enrolled people who were not parents with CF, 717 of them, and then people who became new parents between the ages of 2012 and 2022, and we enrolled 253. We gave them a survey that talked about if, when, and how they became a parent, and then we paired that survey data with data from the CF Foundation patient registry, and that's what I'm going to be showing to you today. The primary outcome that we wanted to look at was lung function, specifically FEV1 through time, and that's what we're going to look at together. But we're also planning to look at pulmonary exacerbations, body mass index, clinic visit attendance, CFRD control, and their microbiologic profiles. We had a lot of hypotheses going into this work, and a lot of them centered around, well, how do you do if you're a mother compared to a father, or a parent compared to someone who was not a parent? And really, what is the impact of being prescribed a CFTR modulator? So I want to tell you about our sample before I tell you about how we analyze this data on lung function. So as you can see in this table, 717 non-parents participated and 253 parents. These groups were significantly different by female sex, with 59% of our parents being female compared to 48% of our non-parents. You can see our race and ethnicity demographics there, which were not different between our parent and non-parent groups. Significantly more of our non-parents had Medicaid or state insurance plans with 25%, and then 17% of our parents. And then you can see modulator use ever, and I just want to call your attention to the bottom line, which is there was no difference here between parents and non-parents, and lots of people were prescribed at one point a modulator, and most commonly elexacaftor, tezacaftor, ivacaftor. Going a little deeper into who was in the study, this is males in the study versus females among the parents. And you can see here that the age of onset of parenthood for males with CF was significantly higher than females, with a mean age of about 34 years compared to 31. There was no difference in the duration of parenthood in this sample. You can see the number of children, the majority of our sample had one child, but a significant number had two or more. And when you think about the number of children, that really comes down to there was no difference between mothers and fathers in our sample. We looked at their FEV1 or their lung function at the onset of parenthood, and there was no difference in this between mothers and fathers. And then unsurprisingly, the path to parenthood was different. So more of our female participants became pregnant, and that was their path to parenthood. In fact, 81% chose that path to parenthood. And then 71% of our male participants stated that their partner became pregnant. So what did we find? Before I get there, I want to remind you of our hypotheses, or our questions rather. So when we looked at mothers versus fathers, this is our analytic plan and what we did, because this data from the registry is complicated and we were looking at it through time. So we only included participants who had at least 3 records of their lung function. We wanted one before they became a parent, one during the year they became a parent, which you're going to hear me refer to as year 0, and then one in that post-parenthood era, and that allowed us to include them in this longitudinal analysis. We conducted linear regression models using generalized estimating equation methods. That accounted for correlations of repeated measures within a subject over time. And we adjusted for a lot of things that were appropriate to adjust for. One was, what was your FEV1 when you began parenthood? Your age, your race, your insurance status, the number of children you ended up having, the number of years you were a parent, and if you ever used a modulator. And that's why I showed you that picture of what goes into this pie of what happens when you become a parent. You can see in our adjustments, that's what we're trying to control for and adjust for, is we look specifically at lung function. So here's what we found. Just to orient you to the graph before we dive into it, this is including 213 of our parents who had enough lung function data to include, 88 males and 125 females. Females are in blue on this graph, and males are in black. Year 0 is the onset of parenthood, and you can see that we controlled in this adjusted model for their lung function at the beginning of parenthood. That's why those dots are really overlaid on each other. And what you're seeing here is that longitudinal FEV1 differed by sex in our multivariable models, and that was significant with a significance factor of a p less than 0.05. When we adjusted for all the things that I mentioned, males had this significant increase in FEV1 from year -2, so 2 years before they became a parent, to 1 year before they became a parent. You can see that in that black line rising. That is a significant change. And then females had this significant drop in their FEV1 from years 2 to year 3. And you can see that in the blue line dropping. You may ask yourself, well, maybe this is because they became pregnant a second time. And when we did this and adjusted via pregnancy, the findings remain similar. And I'm not showing that data here, but I just want to tell you we thought about that too. And it's not showing in this data. It gets more complicated statistically when you think about parents versus non-parents. And the reason for that is because this time period, 2012 to 2022, is when all the modulators came on board and people started taking different things at different times. And we were seeing across the population for CF, big increases in FEV1 for lots of people. So to combat this statistically, we split this group into two cohorts. One is pre-ETI, so 2012 to 2018, and then one is post, so 2019 to 2022. So when we looked at this group, again, including people who had at least 3 records of FEV1, both the parents and non-parents together, we had 716 folks in this first cohort and 700 in the second. We, again, only included people who had pre-year of parenthood and post measurements. But we had non-parents that we were comparing to, so we had to decide on what our year 0 was going to be. So what we decided to do is choose the mean year of parenthood onset for the parent group. So for this first group, it was 2015. So for all the non-parents in the graphs I'm about to show you, year 0 for the non-parents is 2015, and year 0 for the parents is whatever year they first became a parent. We did the same thing for 2019 to 2022, and for that group, year 0 was 2021 for the non-parents, and whatever year it was for when you became a parent for the first time for that group. We use very similar analytics after this, including these longitudinal linear regression models with the same estimating equations, and we adjusted for the same things, including sex. So we adjusted for FEV1 at the onset, and that was FEV1 for year 2015 and 2021 for the non-parent groups in these two cohorts. Age, sex, race, insurance status, number of children, number of years of parent, and ever modulator use. I'm going to tell you this data, but I want to title it Underestimating Purpose. Because when I wrote this grant and when I was about to look at this data, I was very certain, as a parent, that things were going to go south real quick when you became a parent in regards to your health. And I thought there were a lot of mechanisms why that might be the case. And I was wrong, and that's great. So this is what we found, and I'm going to orient you to the graph as before I go through it. This is for the 2012 to 2018 group that I told you about. This is 135 parents and 581 non-parents. Parents are in blue, and non-parents are in black. Now, you're going to look at this graph and think a lot of things, but one thing you may say is, what is going on for year 4 to year 5 for these non-parents? But I want to remind you that year 0 is 2015 for all non-parents. So what you're seeing in that sharp, very significant rise is the impact of ETI at the same time through that population. Parents were still seeing that gentle rise in their FEV1, but it's graduated throughout because year 0 is different for each parent because people became parents at different years. But what I will tell you is your eyes are not deceiving you. The blue line is always higher than the black line, and that is significant. So parents had a significantly higher FEV1, both pre and post parenthood than non-parents. So what happened in the second group? It was about the same thing. So this is from year 2019 to 2022, 109 parents compared to 591 non-parents. You're going to ask yourself what's going on with both of these groups from year -2 to -1. And that is also because year 0 is 2021 for the non-parents, that is the rise associated with more use of ETI across this population. But even still, parents had significantly higher FEV1 post-parenthood in these models. So we didn't know what was going on here. And we thought, well, maybe it's planning, right? So parents are thinking forward about, I have to stay healthy, I want to become a parent, this is what I'm going to do, so it's planning. So we did this exploratory sub-analysis of the data, and we included only parents who indicated paths to parenthood for their first child as their own pregnancy. And we did this because we included a measure in our survey called the London Measure of Unplanned Pregnancy, or the LMUP. And we split this as a binary variable. If you had a 10 to 12, we considered that, and the measure supports that that is a quote unquote planned pregnancy. And if you had a measure of 0 to 9, that was an unplanned pregnancy. So when we included this and adjusted for this in this sub-analysis of this group, it didn't matter, and the findings were really unchanged. So what's next? So we have lots more analysis to do, and I think that FEV1 is part of the story, but I still think we need to look at body mass index and pulmonary function over time in both of these groups in comparisons, parents versus non-parents, as well as mothers versus fathers. And I think we need to dive deeper into the impact of being prescribed different types of CFTR modulators. So those are our next steps with this data. And I presented it a few days ago to our sharing group, and they had lots of other next steps that we should do. So we are going to be doing a lot more analysis, and I hope to share more at future meetings. But I do want to call out that there's a second half to the HOPE-CF study, because what I showed to you in the model of what happens when you become a parent is super complicated. And the CF registry does not include, in a robust way, mental health, support, parental stress, parental responsibility, all these other things that go into the mix. So in AIM-2, we're hoping to do that by recruiting new parents with CF of children less than age 5. And this can be any means that you become a parent. You can adopt, you can have a surrogate, you can become pregnant, your partner could become pregnant. But our hope is to catch them within that first 6 months that they become a parent and follow them for 5 years with routine surveys that are going to capture this comprehensive picture, and then do chart review of their data, similar to what we're seeing in the registry with their lung function, their pulmonary exacerbations, their hospitalizations, et cetera. We currently have 34 folks out of a target of 146. And this QR code actually links to our study team at the University of Pittsburgh. And the reason that's important is that because this is something that we're not drawing blood, we're not getting samples, we're not seeing people in person, we can recruit anybody in the United States who is a new parent within the first 6 months of parenthood. So if you have somebody at your clinic, if you are someone with CF or know someone with CF who this may apply to, we would love to talk with you about the study, about the recruitment, about what's entailed, the compensation, all of those things. So this is how you get to us. And our research team is spectacular, and we'll get back to you right away. But with that, I just want to say thank you, especially to our AIM-1 study sites who allowed us to reach our recruitment goal of nearly 1,000 people in AIM-1. University of Pittsburgh, National Jewish, UT Southwestern, Mass General, University of Washington, University of Minnesota, Johns Hopkins, and UNC, with our fabulous PIs all listed there. But most importantly, I want to thank my research team, who many of whom are in the audience here, and they are the engine that makes everything go. Our funders are indispensable, obviously. But most importantly, I want to thank our community partners and people with CF who influence the design of this study and think alongside with us how we make it better. And then all of our research participants are giving their time to be in this study while they're being a new parent, and that is hard. So I want to say thank you, and I'm happy to answer any questions you have. Thanks.
Okay, we have a couple from the app. So the first is, were there any males or females included in the parenthood study with advanced lung disease, FEV1 under 40%?
Yes, they were included. There was no eligibility criteria that prevented them from being included, and that is one of the key sub-analyses that we hope to do, because I think we as providers, if you're sitting in front of somebody whose FEV1 at baseline is 80, 90, 100, and they're stable there, I feel people feel differently than if someone's sitting in front of you with an FEV1 of 40 or 50. And I think we need to do these same analyses just looking at that group because it matters for people with CF as they plan and think about this, and it matters for us as providers as we're hoping to give evidence-based recommendations and engaged in some shared decision-making around this.
Hello.
Hey, Amalia.
Hi, Amalia, Seattle. So exciting. I am curious if the analysis will look a little bit different if the timing of the modulators is included instead of ever use of modulators. But my questions for you right now are, which of these two messages do you think are the take-home messages from the comparison of FEV? Is it that people who become parents are healthier at the start of deciding to become pregnant, deciding to start a family, or is it that your health doesn't tank at the time that you become a parent, or is it both?
So I think that first question is a really important one, and I think that that idea of the modulator that you're taking, the timing in this time period, we're going to see people who are flipping from one of the lumacaftor, ivacaftor onto ETI. So we're going to see those people flip in the registry. Now, I was really careful when I was talking to say ever prescribed a modulator because the registry is rough. It does not tell you if somebody is taking a modulator. That doesn't talk about adherence. It doesn't talk about dose adjustment in a granular way. So I think that as we do AIM-2, we are including not just modulator prescription, but we're also looking at pharmacy refill data. We're asking participants directly about their adherence. So we're trying to get at that question better. But I think that there's more we can do with the modulator analysis, for sure. And I think that we've been trying to be thoughtful about that because this data gets really messy in the registry as you're looking at it through time, as you know. So I think that that's something I'd love your thoughts on as we're planning that analysis, but it's a good one. I think for the take-home message, it's probably both, because I think there has to be that that idea and that acknowledgement that, like, well, parents are healthier based on this analysis and this sample going in. But I think that the thing as a provider that is hopeful, and I didn't know these results when I named the study, but it's hopeful that people aren't just tanking because their kid enters daycare or they have an infant and it's hard and nobody's sleeping and all of those things. So that I think is something that it gave me shock and it gave me so much joy to look at it. And I think that we have to be thoughtful about crafting this message to people with CF as they plan. Because everybody's values and choices around becoming a parent and if, when, how, and why are very different. And that has to be a conversation. We can't just point at a data point and be like, you'll be fine. So I think that it's really thoughtful in the dissemination.
Thank you for that nice answer, and thank you for saying joy. I'm feeling it.
Yes.
Okay. I think I heard you say we had time for one more. So I really appreciated the presentation. Chris Drescher, I'm a psychologist at Medical College of Georgia. I really appreciated you calling out purpose and the role of purpose. I think that's super important. Anecdotally, we've had several patients whose mental health has really improved, and I think their sense of purpose has really improved as they became parents. And I'm wondering with AIM-2 if you're going to be directly measuring meaning in life or purpose in some way.
It's a great question. And I do not think we have a measure that we've included that gets at that. It doesn't mean that we can't modify the study and think about that. I do think that we are, along with what I showed you for AIM-2, we're conducting interviews with participants because I'm a qualitative researcher by my heart. And I want to understand all the things. And I think we need to dive deeper into this because I think at the end of the day, data is great and helping support people is great. We really need tools to do that and ways to support people and connect people with what they need. And a lot of that may be highlighting and empowering them in purpose and in acknowledgement of what their values are and how their choices are aligning with those. So that's a great comment.
Awesome. Thank you.
Of course. Thank you. All right. Thanks, everybody.
I know there are some questions in the app, and at least one more person that wanted to ask a question at the mic. So hopefully we'll have time to go back at the end and we can ask some more questions then. So now I'm going to introduce our last presenter. So Leah Ritchie serves as a community engagement project lead for the CF Foundation's Community Voice program. She likes to say she's a professional matchmaker, connecting researchers and community members to help increase understanding and improve care for people living with CF. Outside of work, you can find her knitting on one of her many works in progress, looking for her next great nonfiction read, or playing with her golden retriever, Goose.
Thanks so much for inviting me here today. I am Leah Ritchie, and I'm presenting on behalf of this fantastic team from the Cystic Fibrosis Foundation. Here we go. I have no relationships to disclose today. And I'm going to start with a little bit of background to help set the scene for the work that I'll talk about in this presentation. I love being able to start on a good note, and that is our growing adult population among the CF community. As of 2024, the CF Foundation's patient registry showed that we have more than 20,000 people with CF who are adults age 18 and older. That's the bottom 3 bars that you see on that graph there. Even more notable is that, did that work? No, why is this not working? There we go. More than 3,000 of those people are now age 50 and older. Overall, about 61% of people with CF are adults, which is fantastic progress. But along with that shifting landscape comes changes in needs and priorities. And to learn more about those, and also in support of an updated 5-year strategic plan, last fall, the CF Foundation fielded a long-term strategic planning input survey, and I've abbreviated that as LTSP on this slide, with the goals of understanding the community's perspectives around and key priorities around experiences with CF care, research, and programs. This survey was fielded just about a year ago, September to October 2024, across the broader CF community, including adults with CF, caregivers, care teams, foundation staff, et cetera, et cetera. And we cast a really wide net distribution-wise because we wanted as much input as possible. Some of the results from that survey, I just want to draw your attention to the bar chart on the right side of the screen here. The bulk of responses came from caregivers. 33% of our respondents were caregivers. About a quarter were care teams and researchers, and another quarter roughly were adults with CF. One of the chief questions that we asked here was about prioritizing research. We offered 10 different research topics and asked folks to allocate points across those 10 topic areas according to what they felt was important for the foundation to pursue. So the more points they allocated to a research topic, the more important they felt that it was. On this little dot plot, the responses from caregivers are in light blue, care teams and researchers in green, and adults with CF in purple. And across all connections to CF, genetic therapies was given the most points, so the highest priority for research. But among adults with CF, and that's the purple dot, aging with CF, while it was 4th overall, among adults was the 2nd highest priority item. Among caregivers, just for reference, it was number 8 in priority, 8 out of 10. We also included an open-ended response, inviting folks to share their thoughts on research the foundation should consider. In those open-ended responses, adults with CF had more specific concerns around health and navigational related considerations. Some of those include the long-term effects of CF and CF medications, conditions that result from or are made worse by CF, mental health, navigating midlife, et cetera. In general, caregivers mentioned aging complications much less frequently and more generally than adults with CF did. So given that aging with CF ranked as such a high concern, particularly for adults with CF, and wanting to gain a bit more insight and clarity into those concerns, we fielded a follow-up survey in February of 2025. This one was a bit more focused. We asked questions about health-related items, navigational items, and again, included an open-ended question. This time, we sent it only to adults with CF and caregivers, including parents and spouses and partners of people with CF. Slightly more focused distribution, but still wanted to cast a wide net. The respondent demographics looked a little bit different here, and again, I'll call your attention to the bar chart on the right side. For this survey, about 2/3 of our respondents were adults with CF. The remaining third were caregivers. And just for reference, the results from this follow-up survey are the ones that I'm going to present in this presentation today. So let's tuck into health-related aging priorities. Among the 10, 11 priorities that we offered, we asked folks to tell us whether they found these to be high priority, medium, low, or not a priority for them. And you can see on the far, right side of your screen here is the high priority. And folks indicated a high or medium priority for a wide range of health-related concerns, the top 5 of which are progression of lung disease, modulator effects and risks, CF-related diabetes, cancer, and long-term effects and risks of CF medications. Those top 5 were ranked a high priority by about 50% or more of respondents, so these are things that are really on folks' minds. Looking at differences by connection to CF, this is the percent of respondents selecting high priority for these items. Unlike the first survey that I mentioned, where we looked at a lot of different research priorities and caregivers, in this survey, caregivers ranked a lot of these priorities as higher than adults with CF did. The biggest differences were in CF liver disease and long-term effects and risks of modulator use. I always like to include quotes when possible to let the voice of the CF community speak, so I've done so here. Talking about long-term effects of CF medications and modulators, an adult with CF said, long-term impacts of modulators and how bodies age on modulator and how modulator is tolerated through time is key to making future plans. A caregiver said, my biggest concern for my daughter is her resistance to antibiotics. If she lives longer, she may develop resistance. Folks talked about concerns around the physical complications of aging. An adult said we ate high-fat, high-protein diets for most of our lives, and that is definitely going to catch up with us. Another adult offered that they wished to update guidelines in a timely manner for things like cancer screening, especially for people post-transplant and others who are at higher risk for cancer. Moving on to some of the navigational aging priorities. We offered several issues and concerns around navigating life with CF while aging. The top ranked concern here was affording care, including having adequate health insurance. And I'll note again that this survey was fielded in February 2025, before a lot of the budget and policy considerations have come out. So those may rank as even higher priorities now. Second was availability of necessary specialists knowledgeable of CF in one's area and coordinating CF and other healthcare needs. Those top 3 were ranked a high priority by about 50% or more of respondents again. And again, looking at differences by connection to CF, and this is the percent of respondents selecting high priority. Again, caregivers ranked most items as higher priority than adults with CF, with the exception being determining the effects of aging that are related to CF, sort of disentangling aging from CF-specific concerns. Adults rate that as more of a high priority. And again, just to share some of the voices of the CF community who responded to our survey. Talking about coordinating care, when I go to my general doctor or OBGYN, they're afraid to treat me without talking to the transplant doctors. The transplant doctors tell me to go to my GP, but then the GP won't do anything until they speak to transplants. This causes double the visits with less of a result. So lots of inefficient care happening here. People talked about having knowledgeable providers. This one really struck me. A caregiver said that they would like updated education to other healthcare providers. They will not treat our kids in office because they see the CF diagnosis on the chart and think it's a death sentence if they treat them. This is a dentist. But because of modulators, our kids have never had lung complications. Moving on to affording care, a caregiver said, I'm already worried about how we're going to pay for Kalydeco when my husband goes on Medicare. Will his copay assistance stop? Then what? Another caregiver said changes in insurance, whether it's through employers, companies with coverage, or government-driven, create a lot of problems with availability of medication, exacerbating health problems and adding stress again. The bottom line, as an adult with CF said, it feels like I'm navigating a whole new world as CF patients are living longer and there's just not much CF aging data out there. So for some takeaways from this data, as adults with CF are living longer lives, their health needs become more complex, which means engaging with a wider variety of specialists, leading to concerns around coordinating care and having to educate the providers who are not part of their CF care teams. As care teams and social workers, they should prepare to help patients advocate for themselves as they are engaging with non-CF care providers, and especially to navigate a complex healthcare environment. Challenging for any of us, but especially with folks for CF. I'd like to acknowledge the CF community members who shared their time, perspectives, and lived experiences through these surveys. I work with the community voice team, so if you would like to get some community insights, you can scan this QR code, connect with our program. And I'm happy to answer any questions you may have. This QR code actually will bring you to some support and connection services and resources that our team has developed for your patients that you can share.
Thank you, Leah. Before we jump to questions that folks have submitted on the app, I am wondering if you could give a little information about how Community Voice gets members to be involved, and if there are, if CF care teams can reach out to suggest people with CF or caregivers to be a part of the program.
Yeah, absolutely. It's a volunteer program for people, primarily people with CF and their family members. Care team members can point them to the CF Foundation's website. There's a quick, less than 2-minute sign-up form there. Community Voice members work with researchers to help shape interventions, research studies, programs, make them to reduce burdens and make the outcomes align with their priorities and the lived experiences of people with CF. Yeah, thanks.
Leah, that was great. Whoa, this is really loud. Sorry. I wondered, Community Voice is wonderful, and our team has worked with them countless times at this point. I think that when we're doing surveys or interview studies with them, we always are thoughtful to know and to think about that the people who are in Community Voice are highly engaged, highly motivated, and biased in that way. So I wondered if there were plans for other community outreach to kind of check these priorities to make sure that they're representative of that broader CF population.
That is a great question. And I'm peeking towards a couple of my colleagues in the back to see if they wanted to share any input. I can't speak off the top of my head to additional outreach plans, but I can say that we are constantly looking for ways to expand community voice membership to folks who are less represented and maybe haven't had the opportunity to have input into research in the past.
So I helped analyze the survey. One of the reasons why we went out to Care Center, social media, other places was exactly for that reason. Community Voice was about 200 of those completes. Everybody else came from other places. So.
And for context, in that the follow-up survey that I talked about, there were 528 total responses. So that's a little less than half, maybe 40% came from community voice. Thanks, Enid.
Thank you. So we'll now just shift to asking our speakers some questions that came up in the chat. Thank you, Leah.
Okay. Maybe them. Okay. Oh, sorry. Okay, so this was for Kate and Meredith. You mentioned your patients opt in to have this serious illness conversation annually. How do you facilitate that process? Is it through an annual questionnaire or part of your annual assessment?
It's a pretty informal process. That's why, I don't know if you noticed in our graph, there's like a whole chunk of patients that we haven't even approached yet. It's really like we bring it up in clinic if it's appropriate. You know, we say, oh, we have this, we ask them about an advanced directive. Do you want to do an advanced directive? Oh, also we have this video visit that's an option. And sometimes I'm meeting with a patient and they have stuff going on in their lives and it's just like wildly inappropriate for me to bring it up. So it's not anything formal, which is why it's kind of slow going. We just ask them in clinic and we don't, I know a lot of places do like a formal annual. We don't really do that. I'd love to, but there's lots of reasons that we don't. So it's quite informal. I hope that answers your question. And then once they have opted in, then our scheduler calls them and schedules the visit. So.
And then for Lisa and Jen, are there different groups for those eligible for modulators and those not yet eligible? I imagine caregivers might have different experiences upon diagnosis depending on this factor.
Thank you. That's a great question. We talk about it a little bit, but again, we stay away from the medical aspect of diagnosis, and we're really focusing. I mean, most of the families that we talk to they're babies. And so it comes up because it's an issue of hope, certainly. But we're really more focused on just the emotions of the diagnosis, the practical aspects of how to tell family members about CF. I mean, that's one of the modules that we have, one of the early ones, like how to navigate social networking. I mean, those are some other examples of, it does come up because it's a function of hope, but it's not necessarily something we directly talk about. And I did want to acknowledge Rebecca Pressler and Brittany Earwood. We didn't mention them when we did our session, but they're also part of our Bright Beginnings team. And without them, we just really couldn't do this. So just wanted to acknowledge them.
And then this is a question for Tracy. You may have said this, but someone asked, was there an age difference between parents and non-parents?
No. I have to think about my slides. There was not an age difference that was significant. I'm pretty sure. And in the models, we adjusted for age. So hopefully anything that we would see between those groups was washed out.
Okay, thank you. Feel free to keep sending questions. I have one for Kate. Actually, I have a few, but I'll just start with one right now. When you started to implement this, did you find that you had any pushback from the medical team about adding additional appointments outside of clinic, just due to like patient caseload and other types of appointments that were already being scheduled?
Yeah, I mean, I wouldn't say, Meredith can also speak to this because it's really, her time has the most demands on it. I wouldn't say it was pushback, more it was like kind of a logistical journey, trying to figure out how we could work it in. So that was sort of part of the whole PDSA of it all, is we tried it in a regular clinic, And it didn't really work. It just didn't really work. It was not realistic, and it made our clinics, as I'm sure yours do, move really fast, and it wasn't conducive. So I mean, we didn't have any pushback in terms of doing it. I think everyone was on board that we wanted to do it. And so I think it was fine. Like the PFAC are the ones that had the idea to do the video visits standalone. And that actually fits in to Meredith's workflow because she has time that is reserved for her video visits and we can plug them in there. So I wouldn't say there was pushback. It's just a logistical challenge, and we had to experiment a little bit to find something that worked and was sustainable. And then video visits ended up working out too because there's no way patients are going to come in person just for this. I mean, some of them might if they live close, but like many of you, our patients come from really far away, some of them. So yeah, it took a little trial and error to figure out something that was sustainable.
Just a reminder, please come up and grab these Bright Beginnings postcards. If you have to sneak out as we're wrapping up, please feel free to just come up and grab some, as we want to make sure that folks have this really important resource.
We spoke a lot, or not we, you guys spoke a lot today about transition, aging of CFers, and then becoming parents. I'm a widow. 18 years ago, my husband passed. And that's a long time because I know a lot's changed in this community, which I'm grateful for. But during the research in aging and transition, have you been looking at any systems or support for spouses, for even the CFers getting into relationships, because the spouse, the significant other, the girlfriend, the boyfriend, whoever it is, becomes part of the care team, but doesn't always understand CF as they enter into relationships with CFers. And that's something that was a huge missing piece for me when I met my late husband. Was I had no idea what CF was, so I met him. And then I had to try to catch up, right, because he was born with it. So just wondering if that's ever been something that was looked into by any of you or any of your colleagues.
Say thank you so much for bringing up that point. I think it's a really important piece. Thinking about partners, family members, siblings is something we often think about who I feel like can get left out in the mix when we're thinking about folks that need this support. One thing I know the CF Foundation has is the peer support program that focuses on helping to match partners of people with CF to a peer, a mentor, to help kind of guide through and give some of that support, similar to some of the programs that our speakers have talked about. I'll see if anyone else wants to. Yeah, Melissa, thank you.
I feel like this is not a well-known resource, but there is a group of individuals called CF Spouse that provides support to spouses and partners who may or may not be direct caregivers, but are with adults with CF. And I really love to get my hands on some more materials from them if anyone's got a connection, because I feel like lots of people don't know about them, but people have been very excited when I've shared that information with them that they can talk to other folks.
It's projectcfspouse.org, and the person who runs it is wonderful. So that's a great resource to check out.
I'll also add in a plug for CF Peer Connect. They do one-to-one matches based on lived experiences and specific requests that folks may have in a peer connection. Also available in Spanish for somebody who is asking about resources available in other languages. We can make Peer Connect matches in Spanish as well.
I just want to say a huge thank you to our wonderful speakers who are doing amazing work, clearly very dedicated to the important work you're doing and sharing that with our community. And thank you all for being here. Happy last day of the conference.